All right. Answer. The classification of benign and malignant is a little bit complicated in the brain. So a lot of primary brain tumors and intracranial tumors are histologically or morphologically benign, which means they have a low mitotic rate. Their cellular features are pretty well differentiated. They're not crazy anaplastic. They're not invasive usually. So from a morphologic standpoint, they're often benign. They rarely metastasize. However, because we have the jello sponge in the bone jar, any mass in there is going to behave malignantly clinically, right? So all brain tumors, even if they're benign, are bad because you don't have anywhere to expand in there. So the prognosis for individual neoplastic tumors is highly variable. It depends a lot on where it is, how big is it, how fast is it growing. Again, they're often slow growing and not very invasive because they're morphologically benign, but these can affect prognosis. And then just a note, this is very different than in human medicine. Obviously, the owner's willingness to pay for brain surgery and the ability of them to find a specialist who's willing to perform brain surgery also very low, I would think. So yeah, when we're factoring in prognosis for animals, we have to consider euthanasia as a point, not just did the tumor kill you, but did we kill you? All right, so approach, it's all about location. These are some options. Is it extradural versus intradural or subdural? So dural referring to the meninges. Is it outside? Is it inside? Is it actually in the meninges? Is it attached to the skull? Is it associated with the eye, the nasal cavity? Where is it? Is it in the parenchyma or is it on the outside? And then who is it? See item 1. Who is it is determined by where is it. So you ask yourself, what cells live in this location normally? And those are my options for who can be neoplastic. And then you also have to consider, could this be metastatic? The brain is a not uncommon site of metastasis. Here's a tumor associated with the orbit. It's an orbital meningioma. You can have meninges that come out and go around your eyes. Don't forget. Brain tumor. So this is an intraparenchymal in the cerebellum. Looks like it's in the white matter. This one is obviously attached to or associated with the skull somehow. So these are all important clues as to what it could be. Is where is it? All right, so brain tumors that are around the brain but not of the brain. You could get peripheral nerve sheath tumors of the cranial nerves. They are technically peripheral nerves, so you can see them start at the brainstem and come out. Much more common in actual peripheral nerves, like in the soft tissues or in the legs a lot. From the meninges, meningioma is the most common intracranial tumor in dogs and cats, so that's one you're going to see pretty commonly. Most of these are single masses. They're compressive but not invasive, so these often have a fairly decent prognosis as long as they're not growing too fast. You can get masses from the skull, so tumors of bone, cartilage. Multilobular tumor of bone is kind of a weird one. That's this guy over here. All of these are multilobular tumor of bone. So often they go out. If it goes out, it's benign, but this guy is going in as well. So this guy does not have a good prognosis. From the nasal cavity, so adenocarcinomas, and enthesio-neuroblastoma. Blastoma tells you it's primitive. Enthesio-neuro means this is from the olfactory neuroepithelium. So these can go through the cribriform plate and back into the brain. And then from the pituitary. So here's some meningiomas. Here's that orbital meningioma. Here's what's left of the eye. And all this retroorbital space is filled by either often very firm, kind of fibrous almost, very tough. Here's one in the brain of a cat. So here we've removed the top of the skull, and here's the mass associated with the meninges. It's adhered to the inside of the skull. This is kind of hard to appreciate, but there's a flat spot on the brain right here, right where that neoplasm was sitting. So secondary compression, cortical atrophy would be the lesion in the brain. Here's a side view, so brain, meninges, and here's the mass right here. Wow. Here's the mass right here at the top of the brain. Again, it's very firm looking, kind of pink. There's fresh brain, fixed brain. Here's another one. Impressive, associated with the surface. Not, you notice how none of these are really invading. You could just like, and they come right off. Here's another one. Here's one of the spinal cord coming out around the nerve roots. All right, so the point about these often have a better prognosis because they're non-invasive, they're compressive. If you're lucky, they're slow growing. A lot of them are slow growing, so the animal has time to compensate. And some of these masses can get quite large, as you can see. I have a hard time even delineating the extent of this mass. Like it's for sure all of this, all this, and then like I think this is a dilated ventricle, probably. And here's what's left of the cortex. It's just this. So you can see where this is going. Brainstem compression, death, edema. You've got a little bit of coning right here. So this is probably why the animal finally presented is the swelling, right? So what neuroscience do you think this animal might have had? Where are we going to localize? Yeah, cortical science. So what kind of things?
Receptive motor deficits.
Motor deficits, yeah. Circling, behavioral changes. Peripheral nerve sheath tumors. Again, in the CNS, these are going to be associated with the cranial nerves. So here's probably your 7th coming out, and all of this mass around it is peripheral nerve sheath tumor. Again, these are often very tough and fibrous. There's one coming off the caudal brainstem, and then here's spinal cord and nerves coming out of the cord, and all of these are affected, all this thinking. So this is much more common in the skin and subcutis, but any nerve can be affected. So it's on the differential list. Primary brain tumors. So these are going to be gliomas primarily. They have the same consistency as neuropil because they're the cells that are forming the neuropil. So grossly, these can be hard to identify. In human medicine, it's actually very difficult to identify these on surgery, like where is the extent of the tumor versus what's normal brain, because consistency wise, they can look so similar. So look for secondary changes, anything that you'd see with a mass, so asymmetry, shift of midline, herniation across midline, edema and hemorrhage. Most common glial tumor is an astrocytoma, making astrocytes. You might hear the term GBM. This is more of a human thing, but these are high-grade astrocytomas. This is like an anaplastic, very, very aggressive tumor, GBM. Oligodendrogliomas are also fairly common. This primitive neuroectodermal tumor, or PNET. These are from essentially progenitor cells. These are very poorly differentiated. Not super common, but these are like primitive, like embryonal almost tumors. And then you can get epithelial tumors of the choroid plexus, so either adenomas or carcinomas. Here's an astrocytoma. The key to these glial tumors is that they're going to be intraparenchymal, right? They're going to be in the actual tissue of the brain. That's how you know it's a glial tumor. So astrocytoma, astrocytes, remember, form those glial scars. So astrocytomas are often have more structure to them. They're a little bit more firm versus like an oligodendroglioma. They're often very like gelatinous or kind of jelly-like is the classic. So astrocytoma, here's the mass right here. Again, look how similar this looks to just the surrounding gray matter. It's very hard to determine where the borders of this thing are. But there's a nice midline shift that tells you there's definitely a mass in here. It's also some hemorrhage. Another one, cytoma pushing into the ventricle. So this is one that would be a candidate for future obstructive hydrocephalus, right? If this thing gets much bigger and pushes on the mesencephalic aqueduct or the communication between the ventricles. There's one right here. We're following sections through the brainstem. Again, if you look at the contralateral side, this just looks like normal gray matter almost, right? Except it's asymmetrical. It's pushing across midline. Here's a fun. Oligodendroglioma. So these are the myelinating cells, and like I mentioned, these often have a more gelatinous or jelly-like texture. So there's kind of the classic. Big differential for this would be a cryptococcus. A cryptococcus also causes these jelly-like.
I was working for a treatment crew and I saw a goat that was head pressing and kind of similar, and they were talking about ruminal acidosis, and I then looked it up on Merck and I was like, oh, these signs are similar. So
Why?
well, why what?
Why does ruminal acidosis cause neurosigns? What we talked about.
Is it I just remember the thiamine?
Thiamine, yeah. Does anybody remember why? Ruminal acidosis can lead to thiamine deficiency. So thiamine is a cofactor for glucose metabolism, and neurons need glucose for life, right? So that connects thiamine to the CNS signs. How do you connect the rumen to the thiamine and the CNS? Yes, that's their job. Bacteria make thiamine. So when you disturb the rumen flora, you disturb the bacteria and they can no longer do their normal job. And then you get thiamine deficiency, and then you get dead neurons, and then you get polio. All right, so we left off yesterday with primary brain tumors. Again, these can look very similar to the neuropills, so grossly. It can be easy to identify that there's a mass there, but difficult to actually delineate where the borders of that mass are because they look so much like regular brain. Again, this is an astrocytoma. These are often, because they're composed of astrocytes, which make that glial scar, these are often more tough or have like a kind of a firm fibrous consistency. Whereas oligodendrogliomas, these are the myelinating cells. So these are often more squishy, very jelly-like. This is kind of the classic picture here where it just looks like a blob of clear jelly, almost. I will say I have learned quite a bit about human neuro-oncology in the last year, and this distinction that we make between these gliomas is completely artificial. It's actually a little concerning to realize how little we know about these things. So in veterinary medicine, we classify them by what they look like grossly, and under the microscope, we say these cells look like oligos or these cells look like astros, and then we say it's an oligodendroglioma or it's an astrocytoma. In human medicine, they have, and we also give it a grade. Is everybody familiar with the term of grading? So a histologic grade tells you how malignant it is, grade 1, 2, 3. So in human medicine, they don't diagnose tumors that way. They do it all based on molecular markers in the tumor. So they sequence the tumor, and they say it has this, and this mutation, it's an astro. It has this mutation, it's an oligo, it's a GBM. They don't grade them either. They assign grade also by molecular markers. If you have this genetic marker, you have a good prognosis. If you have this marker, you have a worse prognosis. So it's a little frustrating to know that like my entire job could be like totally changed or made irrelevant by a lot of the molecular stuff. Veterinary medicine in general is always kind of like 10, 15, 20 years behind what they're doing in human medicine. So yeah, this classification in real life is a bit archaic, but it's all we've got. We don't have the molecular markers like I do in human medicine. So choroid plexus tumors, the key to these is that they're arising in the location of the choroid plexus. So they often protrude into the ventricles. These are epithelial tumors, not glial tumors. So their appearance would be more that of an epithelial neoplasm. They're usually firm, can form papillary structures. This is kind of a papillary one kind of projecting into the ventricle here. And these guys are especially likely to result in secondary obstructive hydrocephalus. All right, spinal cord tumors. So very similar approach. Where is it? The location is very important. It narrows down your list of differentials to what it could be. So is it extradural outside the meninges, intradural within the meninges? Is it
extramedullary, outside the cord, or intramedullary within the cord. Again, things in the cord, these are going to be gliomas. If it's intramedullary, it's almost certainly going to be a glioma, or potentially it could be a metastatic lesion, right? Intradural, extramedullary, these could be lots of different things. Meningioma could be either one of these. Something like a lymphoma could be either one of these, something that's infiltrative. And then don't remember this. Don't forget that it can also come from surrounding locations. So you can get invasion of neoplasms that are coming from the vertebra, including metastatic lesions, which may met to the lumbar vertebrae, especially urogenital and mammary neoplasms. So Spagnoli had a quote in his lectures about the lumbar vertebrae. He said, it's where the sex stuff goes, because it's brucella, urogenital, mammary carcinoma. So that's where sex stuff goes, to the bones of the lumbar spine. All right, so here are some spinal cord tumors. These are actually two different flavors of the same tumor. So what's the location? Choices? Extradural, intradural, extramedullary, intramedullary. Here's the dura. Here's the spinal cord. Here's the dura. It's extradural. By definition, if it's extradural, it has to be extramedullary, right? You can't have an extradural intramedullary, right? See some scowls. That makes sense. If it's extradural, there's no way. If it's out here, there's no way it can be in here. Extradural has to be extramedullary. All right, so this is extradural, extramedullary. What does it look like? Go back to your GenPath descriptors. Touch it with your eyes. What does it feel like? Soft, I heard it looks soft. What? Spongy, yeah, maybe. I think it looks kind of goopy, almost. It looks kind of wet on the surface. So yeah, kind of soft, wet. It's kind of pale tan. Doesn't look like it has much structure to it. It looks like it's kind of taking the shape of whatever it's been in, right? And then here's the other flavor. So here's the spine, here's a nerve root, and it's surrounding the nerve root. This is also extradural. It's a little harder to appreciate, but trust me. All right, so what do you think it is? Let's go back to the list. So what can it not be? What can we rule out from this list? It's not intramedullary, so therefore it is not a glioma. These are intramedullary, not a glioma. Peripheral nerve sheath tumors, meningiomas, ependymomas, what is the texture of those? They're firm, yeah, and fibrous. This does not look fibrous at all. It looks like the opposite of that. It looks like if I touched it, it would turn into soup. Ependymoma would be in a ventricle, right? So that's not going to be an extradural lesion. Chondroma, chondrosarcoma, what do you think? For sure not. Yeah, no, these would be firm to hard even. These can have bone in them. Multiple myeloma. That could be soft, right? Coming from the vertebral body. It would be weird to have it this well demarcated if it's crawling out of vertebral space, right? You'd expect it to, you'd have bone destruction in the vertebrae, you'd have pathologic fracture, right? All right, so what are we left with? Metastatic or lymphoma. This is lymphoma. So classic lymphoma appearance, not just in the spine, but anywhere, it looks soft and white and goopy because it's just lymphocytes. There's no structure to it. It's just white cells. Okay, so here's another spinal cord tumor. These are also different flavors of the same type of tumor. So where is it? Intramedullary. And this guy, a little harder to say because like there's this dividing line here, right? But it's definitely what? It's definitely intradural, yes. This one's definitely intramedullary. By definition, if it's intramedullary, it's got to be intradural, right? So you can skip that part because it's apparent. This one, I'm going to tell you that this little slit right here is the central canal, if that helps you out. So this is also intramedullary. It's just much larger and much more compressive and more difficult to tell. All right, so what is the classic intramedullary neoplasm? It's a glioma. Yeah, so it's either an astrocytoma, an oligodendroglioma. And we'll never know for 20 years until we get the molecular markers. All right, another one. Where is it? It's intradural and extramedullary. Good. So what does it look like? Feel it with your eyes. It's not hard. So hard would be bone. So it's either firm or soft. Hard to tell. This is a fixed specimen. So everything's firm. Even soft stuff becomes more firm when it's fixed. So I agree, it does look kind of firm. It's very well demarcated. It's taking the shape of the space that it's filling, right? So that is, to me, is an indicator of probable softness, right? Because it's just kind of like, it's like toothpaste, like squirting into the dural space. This is all it here. So we're looking top down or bottom up, I'm not sure, on the lesion right here. And see how it's kind of formed like a pancake in there? Like it's like someone took a round lesion, like a cookie dough, like a blob of cookie dough, and then they just went on top of the spine and it took the shape of this area, right? That's what it looks like. So probably soft. What is it? By the same process of elimination we did for the other one. This is lymphoma again. Surprise, it's always lymphoma. All right, one more weirdo spinal tumor, the canine spinal nephroblastoma. Nephro does mean kidney. Blastoma, remember, means something very primitive, like a precursor cell or something embryonal. Kidney is the most common site for these tumors, but there's a weird syndrome specifically in young large breed dogs. German Shepherd is the poster child because they are the poster child for everything. They have so many posters. So this is the result of fetal remnants that get trapped in the spinal cord as the kidneys migrate during development. So don't memorize anything about kidney embryology, but basically the mesoderm migrates kind of down here and goes very close to the spinal cord before it comes down here and becomes a developing metanephros, which is the kidney in the urogenital system. And this is abnormal cellular migration in these guys. So they get little pockets of cells that become trapped in the developing cord. So here's neural tube right here, and this will eventually become the spinal cord. So these get trapped and they make a little pocket of tumor in the spine. So these guys present with usually T3 to L3. It's in the region of the kidney, chronic progressive myelopathy, similar presentation to any spinal tumor, but it's kidney tissue in there. So, and to prove it, ta-da! So here's the cord, here's the tumor. It's pretty well demarcated. It's pink. It looks, I don't know, soft to firm. Can't really tell. Not quite lymphoma-y, but does still look kind of squishy. And then when we look at these under the microscope, these are little fetal glomeruli and little abnormal dysplastic tubules that it's trying to make. It's like, don't take me out, I'm working. Remember that tumors that are morphologically benign often still behave malignantly because you have limited room for expansion, especially in the brain. Location is critical. This is true for neoplasia in anywhere in the body. Ask yourself, where am I and what cells live here normally? Those are the candidates for who's going to become neoplastic. Don't forget metastatic lesions. Most common intracranial tumor in small animals is meningioma, and lymphoma is super common, especially in the spinal cord and especially in cattle, although I have seen it with some frequency in dogs.